The first quick answer is it's an American proposal, because I'm not sure exactly how or even whether it applies to the context of a national health service. But in the case of a country like America, with mainly private health care funded by insurance companies and some funding from the government, then the situation looks a little different, and I think has certain advantages. What we want to ask is, how do we protect the rights of patients without forcing the doctors to do what they think is immoral? And my proposal, which I developed with Aaron Ansel, a graduate student at Duke, is to use those market forces to produce improvement in the healthcare in both sides. Just to make it concrete, let me give you an example. Guadalupe Benitez was in California, wanted to have a baby, needed artificial insemination to have a baby, went to a clinic, and the doctor said, "I'm not going to give it to you." Why not? Because she was a lesbian. Her partner was a woman. And the doctor said, "For my religious beliefs, I cannot give you this treatment." And as a result, Benitez had to go to a different clinic that did not take her insurance and lost thousands upon thousands of dollars. Ended up with a beautiful young child that you can find a picture of on the internet, but had to pay a lot of money and sued to recover those costs because her insurance company would have paid for the service at the first clinic. What Aaron and I want to do is look for a solution that will avoid forcing the doctor to do something in a situation that's very problematic, but also will protect the right of Benitez to have a child with her partner. So how do you do that? Well, we have 4 rules that we want to say should be followed. Number 1 is publicity. If the clinic wants to say, "We are a clinic for treating married couples," they should say that. It should be in their literature. It should be on their webpage. That's our clinic. Just like you can have a clinic that's a women's clinic for female patients, you should be able to have a clinic for a certain set of patients. But you ought to say it on the door so that when Benitez wants to have treatment, she doesn't have the embarrassment of going to this place and being told that her lifestyle is wrong and therefore we're not going to help you. Second, a referral requirement. If this clinic is not able to do the operation because of their moral scruples, I guess they're able to, but they don't want to because of their moral scruples, then they need to refer the patient to a doctor who can. Now, that doesn't mean that they're recommending to this patient that the patient go to this other clinic. They can even tell the patient, "I don't think you ought to have a child until you're married." But they should inform the patient that other people can perform this service, and this is where you find out those people's names. All you gotta do is give them a link to a website. Tell them they can check the American Medical Association website or whatever website it is. That's not endorsing what they're doing. And if they're not even willing to do that, then it seems to me they are showing a disrespect for the other doctors who make a different choice. And then it becomes hypocritical and unacceptable for them to say that we have to respect their principles when they're not willing to respect other people's principles by viewing those principles as reasonable and something that the other patient can go along with. So there's a publicity requirement, they have to refer, and then there's a compensation requirement. The real problem in the Benitez case was that when they went to another clinic, they found that other clinic on their own. That other clinic did not take their insurance and they had to pay. So now we've got a problem. The doctor's principles are costing the patient money. There's going to be a loss. Who is going to suffer the loss? The loss might be suffered by the patient or it might be suffered by the doctor. Well, it's the doctor's principles who are creating the problem. And so it seems to me that the doctor ought to pay. There's a general principle of tort law. We ought to distribute the burdens in certain ways so the people who are more at wrong and are more able to pay should pay. And in this case, that's the clinic. Notice we're not focusing on the individual doctor. We're focusing on the clinic. Now, why is that? The reason is that the clinic, if they want to avoid paying this compensation, they can hire a doctor who's willing to treat unmarried patients or lesbian patients. Well, that's up to the clinic. It's just a financial decision. But if they don't, they're going to have to pay for the service elsewhere. So now what you're doing is you're using the market forces, the finances of the doctor-patient relation to put pressure on the clinic. Because if they have to hire another clinician or else pay compensation, then they're going to be less inclined to hire clinicians who won't treat these patients. Maybe they will if they're particularly good and if it's a big enough clinic that they don't have to hire somebody else. But they're going to have to hire more people. So you put financial pressure on the clinic to make sure that the services are provided and no one has to suffer an undue burden. Benitez and her partner can have the child that they want and deserve and don't have to pay the extra money for it simply because the two local doctors happen to have certain principles. The fourth principle is just an exception. Namely, doctors should be able to avoid complicity. If a patient comes and says, I want to be treated for erectile dysfunction so that I can rape more young boys and girls, then the doctor should be able to say, no, I am not going to write a prescription for Viagra if I have good reason to believe that you're going to use this treatment to rape young boys and girls, because I don't want to be complicit in that. So one limit that Aaron and I would want to place on our framework is to say that it only applies when the patient is not planning to do anything illegal, as Benitez was not, because her relationship with her partner was totally legal in California at the time. Each of these principles is very complicated, needs a number of qualifications, but the general framework, I hope, is clear, that we want to use market forces to lead society in the right direction so that clinics will have to hire other doctors who will perform services to these groups or else pay compensation. That's financial pressure, which will make them less likely to hire doctors who refuse to serve these patients, will make those doctors who refuse to serve these patients have to accept slightly lower wages, and will eventually lead to more and more people being willing to serve these populations. All that is achieved using the market, using financial pressures, instead of using the heavy hand of law and forcing doctors to go against their consciences and their moral beliefs. So the hope is that that is a solution that might take a little more time, might not be ideal, as no solution is, but will protect values on both sides. So it's a very different situation when there is a National Health Service, because the people who are hired by the National Health Service are hired to treat certain classes of patients. And you can just build that into the contract that says you're providing fertility services, you have to provide them to everyone. You cannot pick and choose your patients. That can certainly be written into the contract, and my understanding is that it is written into many of the contracts. But notice that it doesn't have to be that way, and so then society has to choose how to write those contracts. You could, for example, have a contract that says you are a general practitioner for women, and you're a general practitioner for men. You don't have to sign up to be a general practitioner, where you have to take one class of patients or the other, whoever shows in the door. Because if you're a Muslim female doctor, you might have qualms about inspecting men. Or if you're a male Muslim doctor, you might have qualms about intimate inspections of women based on religious grounds. Now society has to say, well, should the specialty be, general practice or, sexual dysfunction or whatever? Or should it be male sexual dysfunction, female sexual dysfunction? Now, you can take a National Health Service and define the specialization either way. sexual dysfunction, or male sexual dysfunction, female sexual dysfunction. The question for society is, which way do you want to set it up? One way leaves the Muslim doctors more free to treat only the patients they think it's appropriate for them to treat, and it therefore encourages more Muslims to enter the National Health Service and work for their communities, and therefore provides services to those Muslim communities that those people feel more comfortable with. But it also is going to lead to more segregation, to potential discrimination. If there aren't enough female Muslim doctors, it might lead to inadequate services for female Muslims. And so now you've got your trade-offs. And how do you pick those trade-offs? Well, you have to look. How many female Muslim doctors will there be? How many female Muslims will only go to a female Muslim doctor? How many, there you need to look at the particular circumstances, it seems to me, as to how to set up the service. But I do not think, to get back to your question, I do not think that the National Health Service avoids the problem. It just pushes the problem from what's the clinic going to do to how does the National Health Service define specializations. And that's the same issues are going to arise at a different level in the system. I do not want to saddle Aaron with this controversial claim, and some of my friends will probably hate me for saying this, but I'm almost inclined to say, yeah, they should be allowed to, subject to our requirements, including publicity. This restaurant will have a sign on the door that says, "We don't serve blacks." And I will be the first one to protest. The NAACP and all kinds of right-thinking people will immediately jump on them, and they will lose so much business that they will go out of business, and I will be happy when that happens. I think it would be great if the next day after this waiter refused, 5,000 people showed up to protest this restaurant, to show the black people in that community, we're on your side. We think this is outrageous. Now you get a public statement, not a policeman acting as an authority coming in with a gun forcing them to do it. Let's let the public show what they really feel about this. What's the best way to bring about change? To force the issue and expect the cops to do it in one fell swoop overnight? Or to change society by showing through your numbers and your protests what people in general really think? I just think the changes are going to produce less backlash and better feelings through groups of people speaking out against the abuses instead of bringing the cops in to try to make it happen today. It's going to take some effort. It's going to mean we got to organize the protests. We got to show up at the protests. We've got to make sure that our voices are heard instead of sitting back at home saying, "Isn't that horrible?" But maybe I'm a child of the 60s, but I remember having fun at protests because everybody was on the same side, fighting for rights. And it's like, let's get back to that instead of telling the cops they got to do it for us. More protest.